laparoscopic tubal surgery, and in that we will discuss first the ectopic pregnancy, how to deal with conservative versus operative, and then we will discuss the salpingo-oophorectomy, how to perform, salpingotomy, how to perform. So basically the tubes are alone not necessary to take out unless it has some ectopics. Indications are very less. Here we can see that this is the tubal anatomy. This is uterus. This is known as interstitial or intramural junction, and this is the interstitial and intramural part. This is isthmus part. Here this is the ampullary part, and this is infundibular part. So these are the four parts of the fallopian tube. In these all four parts, generally in laparoscopic surgery, interstitial part, if it has the ectopic, then it is contraindicated. Even if you have to perform salpingectomy, remember, even if you are doing LAVH also, then your first incision should be at the isthmus part, not interstitial. Because if you will go very nearer, reverse bleeding can start from the uterus side, and that is difficult to handle. This is first. And second, that if you are performing only salpingectomy, if you are very nearer to the uterus, then you can damage the ascending uterine hair, and there is a risk of revascularization of the ovary. So just to prevent that, your incision must be 6 mm to 1 cm away from the uterus. And then you can start medial to lateral if you want to perform salpingectomy. For salpingotomy or salpingostomy, your incision should be anti-mesenteric border of the tube. And you should use the sharpest instrument available. Remember, sharper is your instrument, less collateral damage you will get. Even the hook is not good to do salpingotomy. If you use hook, the margins will get collateral damage, burn. And if you want to approximate, it will not heal. So you should use the tritome, that is the sharpest instrument, or tip of the aspiration needle to cut during salpingotomy. So this is the interstitial part, this is isthmus part, this is ampullary part, and this is infundibular part. Now here it is known as mesosalpinx, and this portion is known as meso-ovarian. Here we have the ovary, this is ovarian ligament, and this is infundibulo-ovarian ligament, and this is the infundibulo-pelvic ligament. In the infundibulo-pelvic ligament, you have the uterine artery coming, ovarian artery coming, that is the direct branch of the aorta. So this mesosalpinx and meso-ovarian makes a fold, and then it gives rise to the broad ligament. So this is the anatomy which we have to keep in mind. Now coming to the topographic anatomy of the ectopic pregnancy. Generally, ectopic pregnancy occurs in the tube in 99% of the cases, whereas in 0% of the cases it may be ovarian, and again 0.4% it may be abdominal, and sometimes intra-ligamental also it can be there. So in rare situation there may be chances of ovarian pregnancy and intra-abdominal. Now here we are more concerned about the tubal ectopic pregnancy. In tubal part, in the ampulla it is 64%, in the isthmus it happens 25%, in the infundibulum it happens 9%, and in the interstitial region it happens very less, that is 2% only. So this way completely you have the more incidence in the ampulla followed by isthmus. So maximum cases, approximately 85 to 90% of the cases, it will be here only. OT setup is same way as any of the other gynae surgery. Surgeon stands to the left of the patient, camera person will be right to the patient, one assistant will be in between the leg, and you will use your instrument to work. Harmonic will be, or you can use the other. It is very important to remember one thing I will like to tell you, that harmonic scalpel is not a good instrument for tubal ligation. Never use it. If you want the tubectomy, you can use the bipolar. Incidentally, I am saying it is out of this course, but because I am discussing the tube, that's why I am saying that sometime if you are doing the appendicectomy or doing the ovarian cystectomy, patient will tell that she wants the tubectomy also, and you have a harmonic and you will cut. Don't do it, it is contraindicated, because it can get recanalized and it will get the fistula, because harmonic is a vibration energy, so it doesn't seal much, and before sealing it will cut and your opening may remain patent. You got it? Because of less collateral damage. So we need collateral damage there, so that it should be completely fusal lumen. So this way you have to keep in mind. Now patient and port position. Patient should be left to the surgeon will be left to the patient, and one assistant you need in between the leg. And camera person will be just behind and right to the surgeon. Once you start surgery, then this way position one port into the umbilicus, another port in the left iliac fossa, another on the right iliac fossa. It completely depends upon which side pathology is. If pathology is right side, surgeon stand left; pathology left, surgeon stand right. This is one table given by Pauli and others. What do they say? That although it is not applicable in every hospital, it varies country to country also. Religious factors are also predominating there. Like especially in the Middle East countries, if you will ask for taking the tube out, it's a crime. You cannot speak also like that, even if the patient has ectopic. And if you will do some tubal destruction on both the sides, then generally the husband gets another marriage. So it's completely, a lot of religious factors are there. So in those situations it is different. But as of the developed country like USA and all, Pauli has given this score. And in this score there are different points given for different pathology. Like ectopic pregnancy, previous history, 2 points. Laparoscopy, 1 point. Contralateral adhesion, 1 point. Tubal microsurgery, 2 point. Unique tube, 2 point. Salpingitis, 1 point. If you will calculate those points, and if a score comes 1:3, that means conservative treatment is better. What is conservative treatment? That is salpingiotomy. And if a score is 4, then it is better to do salpingectomy. And if a score is more than 4, then salpingectomy with contralateral tubal ligation. And if patient wants to get baby, send for IVF, because in those situations further risk is much high and there may be recurrent ectopic to the other side also. So this way, but it is not a strict criteria, not accepted worldwide. First we will see how to do salpingiotomy. If you are planning for salpingiotomy, your first step is preventive hemostasis, and for that you should give the complete tritom should be given. This is the tube here, and first you should give the vasopressin. This is ectopic, and you should give vasopressin. And how to do that? You will stabilize it here, and just you will inject here, preventive hemostasis. What does it mean, preventive hemostasis? Here is the uterus, this is the tube, this is ectopic. And what is this? This is mesosalpinx. And you can take a separate spinal needle, percutaneous, yes. Or if you don't have that much privilege because of the deranged ergonomics, then you can go with the aspiration needle also with one of the port. And then just you pierce it and then start giving superficially just below the peritoneum. And slowly you will see that it start giving bleb. Can you see here? Its bleb is coming. Now this bleb is important. Why? If you don't have blade, that means it is not good. This is the blade. Here is the ectopic and this is the blade of the vasopressin. How much vasopressin? 5 international unit of vasopressin should be diluted with the 20 ml of normal saline. And then you have to give it, and we can see here that slowly this blade is formed. Now this is known as preventive hemostasis, and this is very important step. Remember that you don't give much deeper. If you will give much deeper, then your anesthetist will cry, because it is sometime giving more systematic effect than the hypertension, tachycardia, pulmonary hypertension, all starts. So 5 international units of vasopressin should be diluted with the 20 ml of normal saline, and injection of the vasopressin creates transient local ischemia there, and that prevents your bleeding, because one of the mainstay of the conservative treatment is hemostasis, main problem. In destructive treatment it is not a problem, because you can apply energy source and you can destroy. But in the conservative treatment, suppose you have done the salpingotomy and after that it is bleeding, now you cannot apply the current there, isn't it? Otherwise your purpose of having this conservative treatment is lost. So this way you have to use. And now you can cut the anti-mesenteric border of the tube. How much you will cut roughly can be calculated with the help of the how much diameter the tube is. Like here we can see this is the 2 centimeter diameter of the tube, and then you must cut at least 2 centimeter to evacuate the complete trophoblast without rupturing it. So that's why it has to cut an anti-mesenteric border. Remember that don't go nearer the mesosalpinx to cut, you will get more bleeding. And for that, stabilizing the tube nicely with the help of the grasper is important. And this way you can do, and after that it is cut, and then you introduce your suction and start sucking. Sucking should be very gentle so that there should not be much damage, and you should aspirate it in such a way that it should come out slowly. And how to suck, we will see here that just you can stabilize it. Here is the uterus, this is uterosacral ligament, this is cul-de-sac, and this is ectopic, and here already vasopressin is given. Now this is tritom, and with the help of tritom you can cut the anti-mesenteric border of the tube with the cutting current. Remember, don't use here the coagulation current, because it will give you more collateral damage. Always remember that cutting has less collateral damage and coagulation has more collateral damage. Why cutting has less collateral damage? Because due to the high frequency of turbulence of ion inside the cell, when you will touch it, the cell which is evaporized is not there, and the cell just by the side is completely healthy. But in coagulation, due to the low frequency, high voltage current is there, and in those situations always a dead tissue is there. So I don't want a dead tissue, it should be cut. And now once it is cut, although little bit hemostasis and little collateral damage will be there also, but minimum. And in instrument, actually the instrument has to be little bit negotiated in the way that suppose you have the port position, how you will put, I will just demonstrate you. The port position in this surgery depend upon the which side of the tube you are doing. Like suppose you have, this is the uterus and here is this is the tube. Now suppose you are working of this side of the tube, then this port will be here and this port will be here. You got it? And then you will stabilize. And another important point is you have privilege of uterine manipulator also. So what you can do with the little uterine manipulation, you can bring the uterus here, isn't it? And then the tube will come to the midline, and this is the port from which you can introduce it like this. You got it? And this way you can perform and you can put the suction from here, and you can give the lateral traction from here. So this way you have the privilege, and this is the same thing which is going here. Can you see? And uterus will give you little privilege. This privilege only is there for the gynae procedure. This privilege is not there in the general surgical procedure, because in gynae you can mobilize the uterus right and left, and almost the tube is a mobile structure, and then slowly you can see here this trophoblast is coming, and gentle from the proximal aspect you should pull. Distally here you cannot pull. So proximal aspect you will keep on pulling slowly, and it will go here. If it is creating much problem, then it may break. You will not be lucky always to coming out like that. Here complete trophoblast was delivered, but you may not be that much lucky, and in those situations you may have to use some other method like suction irrigation, and sometimes milking is required. So we will see this video again how to do that. Just you bring the tritome or aspiration needle and cut the antimesenteric border of the tube, and this is how much you will cut. It depends upon the diameter, how much diameter it is. Here it is 2 centimeters, so you cut 2 centimeters only, and this way it is cut. Now you introduce and suck. In the tritome all the 3 functions are there. That is, you can inject the vasopressin also, you can do the suction, and you can use energy also. But if you don't have that, then you use the aspiration needle to cut and introduce the suction to suck. So low pressure suction should be used, otherwise the tube itself will get trapped there. Low pressure suction, and slowly you try to pull it under little traction and take your time, and it will get completely aborted. It will come out. So slow movement, gentle traction, and it is out. And this way it can be delivered. So this is the way of doing the unruptured ectopic pregnancy. Now sometime what happens, that the conservative treatment is contraindicated. The 2 contraindications are more than 6 centimeters in diameter, that much big. If the tube is there, then there is no any good idea to preserve the tube. Tube is completely destroyed anyway. And if you will try to do conservative, you may turn up into a problem because of excessive bleeding. Another HCG level more than 15,000 international unit also is one of the contraindication. Relative contraindications are cases with poor pregnancy prognosis and severe adhesion. In those cases also not should be done. Generally in our country, if you have a little doubt that there will be much bleeding and all, we do salpingectomy generally. But it depends upon you are the best judge, and you have to decide with the consent of the patient. Always remember that even if you are planning for conservative treatment, take a consent from the patient of salpingectomy, because sometimes just during anesthesia itself it gets ruptured, which was initially supposed to be unruptured. And once you will enter inside, you will see a lot of bleeding. In those situations, you have not any option except doing the salpingectomy. So the consent for salpingectomy is a must before surgery. Now, when you are doing salpingectomy, always you should go medial to lateral. Why? Already I have discussed later, that to get the better ergonomic, because the bipolar or seizure will come from this side and you need lateral traction. Medial traction will be given by the uterine manipulator and lateral traction will be given by your instrument. And that way slowly you can go and you can cut medial to lateral. During that dissection, remember that you should try to remain as nearer as possible to the tube. So this is uterus here and this is tube, and slowly you can go ahead and you can do salpingectomy. Salpingectomy is not a very difficult procedure. It's a basically easy surgery.